So Dr. Caulfield received her Doctor of Pharmacy at the University of Florida and followed that with a 2-year fellowship in family medicine at the University of Florida under the direction of Dr. John Gomes. Her career experience includes the West Palm Beach VAMC and the Peace Health Southwest Medical Group residency program in Vancouver, Washington. Currently, she's Associate Professor of Pharmacy Practice at Palm Beach Atlantic University's Lloyd L. Gregory School of Pharmacy, and she coordinates and teaches in the Neurologic and Psychiatric Pharmacotherapy series. She additionally maintains an ambulatory care practice site at a local safety net clinic. Please join me in welcoming her.
As far as I'm concerned, and obviously this is going to be a bias, this is the coolest subject today. So let's have some fun with it. Okay, so I have no conflicts of interest to disclose, but I will tell you that I will be talking about off-label uses for medications. Psych is kind of a mystery, and so there tends to be a lot of using different agents for different conditions, and a lot of it is not necessarily supported by clinical trial. So learning objectives are, as in your slides, I'm going to go ahead and launch right in. So as you see, we're going to be looking at 6 different conditions. What I'm going to do with each of these is you have extra cases for my portion of the talk. I wanted you guys to have as many examples as possible. So let's go ahead and launch into this with schizophrenia. We have our first patient, who's a 24-year-old man with schizophrenia, who's not responded to therapeutic trials of fluphenazine and quetiapine. He is socially withdrawn and unable to care for himself. Although his hallucinations have decreased in severity, they continue to be troublesome. He speaks little. When he does, his speech is disjointed, bouncing from topic to topic without any logic. So we've got a couple different things to consider in this case. And first of all, I'd like you guys to take a shot at which antipsychotic you think is the best choice, whether you think it's aripiprazole, clozapine, haloperidol, or perfenazine. Okay, I'm seeing a lot of red, a few blues. So good. The red is actually the correct answer. So let's go into a couple concepts here. The first one is with regard to schizophrenia diagnosis. Now, this guy has a schizophrenic diagnosis, but you may wonder what goes into it. A couple years ago, we had the release of a new diagnostic and statistical manual of psychiatric conditions, the DSM-5. And they've changed some ways to look at some of these conditions. So for schizophrenia, patients have to have a number of symptoms. The whole duration is over 6 months, but they need to have at least 2 within the same month. So they have to have at least one of the first 3. So delusions, hallucinations, and disorganized speech. And we'll get into those a little bit in the next slide or so. So we know our patient has hallucinations, which is it's what's called a positive symptom. And that means that it's something there that shouldn't be. So these patients are seeing things that aren't there, hearing things that are not there. Sometimes they feel things that aren't there, like feeling like they have bugs on their skin. Usually, though, it's auditory or visual. And our patient has that. He also has disorganized speech. Disorganized speech means that, and again, this is a positive symptom, something that's there that shouldn't be. Their conversations are not straightforward. They may have tangential thoughts, so their conversation kind of bounces from one topic to another. Sometimes it's entirely disorganized, called a word salad, where they're just saying random different words. And then he also has what are called negative symptoms. So I talked about negative symptoms and positive symptoms. As I said, positive symptoms are something that's there that shouldn't be. So in addition to the hallucinations we talked about, they can also have delusions or false fixed beliefs. Paranoia is quite common in these patients, as is the different unusual ways of speaking. A negative symptom is something that's not there that should be. So these patients tend to have kind of a flat affect or without emotion. They'll be socially withdrawn. They can have what's called poverty of speech, where they don't talk very much. And if you talk to them, sometimes it'll take a while for them to respond. So that'll be important here in another slide when I talk about antipsychotics. They can also have some cognitive decline. Unfortunately, we don't have any medication that will treat that. Antipsychotics address the other two. So moving on from schizophrenia diagnosis, which it's good to know what symptoms a patient has, so you know how to treat them. We have two classes of antipsychotics. So we have first-generation antipsychotics and second-generation. And the agent that pretty much shows that divide is Clozapine. So before Clozapine, the first generations or typicals were all that we had. They're pretty more a uniform class. You expect the same side effects from this class, and you can classify them into one of two classes. Low potency, like chlorpromazine or thorazine, which tend to have more anticholinergic effects. And then you have high potency antipsychotics like haloperidol. Those tend to have a little bit more of the EPS or movement type of disorders. So what makes it good as a uniform class is that you can switch from one dose to another. We know dose equivalencies. And they're very useful for schizophrenia, particularly for the positive symptoms. But contrary to what you might have heard, they can work against negative symptoms too. So the drawbacks are abnormal movements, which we'll talk about a little bit with our next case. They can also cause hyperprolactinemia, which can lead to sexual dysfunction, impotence, and also gynecomastia. So the second-generation antipsychotics we also have called atypical, and I'll explain that in a moment with Clozapine. So the difference here is that there's a little different binding in receptors in the brain. So first generations are primarily a dopamine antagonist. But with second generation, we add in some serotonergic antagonist activity. When this first came out, we thought that this meant that it would be more beneficial against negative symptoms. So the flat affect, the social withdrawal, those types of things. But we're not so sure about that now with some of the more recent trials. The Katie trials showed that perfenazine is comparable to the second generation. But we do think that this might have some more effect on affective symptoms. So you're going to see these antipsychotics used for all kinds of other things, which is why I wanted to introduce them first so you can see how they apply as we go through the different conditions. However, these agents have their own drawbacks. The side effects are a little bit more scattered throughout the class, but the things we tend to worry about the most are with regard to metabolic syndrome. Several of these agents can cause a significant amount of weight gain, and they can also increase the risk for diabetes. So why do we use second generation so often over first? Probably the biggest issue I can think of is tardive dyskinesia, because that still is pretty common with first generation. Can happen with second generation, but not as often. Tardive dyskinesia, of course, once patients develop it, there's really no treatment for it, and it can be very disabling. So let's kind of stack those concepts together with regard to treatment-resistant schizophrenia, which is what our patient has. Our patient has failed to respond to two different antipsychotics. Before considering Clozapine, the patient should be tried on one first generation. In this case, it was fluphenazine, and one second generation. And in this incidence, it was quetiapine. And in that case, Clozapine is the agent of choice. It was first studied as an antipsychotic in patients with treatment-resistant depression. The other options there are suboptimal. Aripiprazole is the second generation. Both haloperidol and perfenazine are first generations. Clozapine is probably underused. It is very effective. It was an amazing antipsychotic when it first came out because patients who hadn't responded to anything else did. It was wonderful to watch them wake up from their schizophrenia when placed on this agent. But it does have its drawbacks. So as I said, it was really the first atypical antipsychotic. It was considered atypical for several reasons. The first was that it appeared to have different effects on schizophrenic symptoms, more effects on the negative symptoms. This one, you can say, has more benefits on negative symptoms than any of the first generations. It also was not associated with movement disorders, and it's the only second generation that isn't. So it was atypical in that way. And it also had these additional binding properties within the CNS. So that's what makes an agent atypical, but clozapine's the only one that's really lived up to that. Not only is it indicated for treatment-resistant schizophrenia, but it's also indicated in patients with schizophrenia who have suicidal thoughts. Why don't we use it more? Because it has a serious side effect. As you probably all know, it can cause dangerous drops in white counts. When this agent was first brought to market, there were actually 4 deaths related to agranulocytosis. So that's why we now have the monitoring program we have. Has anybody helped monitor clozapine in the outpatient setting? Okay, so quite a few of you. What's the paperwork like? Pretty heavy, right? This agent was so beneficial that they decided to start a monitoring program because for some patients the benefits just outweigh the risks. So patients have to get their ANC measured every week for the first 6 months. Patients can only get a week's worth of clozapine. The pharmacist has to receive and interpret that ANC to determine if the patient is able to get their dose. So if their ANC is less than 1,000, you interrupt treatment. If it gets to be less than 500, you stop and you don't re-challenge. This actually is probably the first drug that made every pharmacist a clinical pharmacist because you have to interpret a lab in order to dispense the drug. So let's go on to our second case. We have a 29-year-old woman with cardiomyopathy who has a history of pseudoparkinsonism and hyperprolactinemia on haloperidol. She developed akathisia on lorazepam. Her BMI is 24. She's actively psychotic, and her hallucinations keep her awake at night. So, which of these antipsychotics would be the best choice? Brexpiprazole, cariprazine, clozapine, or quetiapine? What do you guys think? Okay, I'm seeing a few here. You guys must be getting tired. Good, I'm seeing a lot of yellow. Excellent. So, yes, quetiapine would be the best answer. So here let's talk first about response to therapy versus treatment resistant. So side effects, like this patient had with her 2 agents, do not equate to lack of response. So you're in a different ballgame with regard to that. So clozapine would not be your agent of choice in this case. So let's look a little bit more. Oh, and that's the other thing. Clozapine has a lot of other side effects, which I've outlined for you in the book. But because this gal has a history of cardiomyopathy, clozapine also would not be a good choice because it can cause cardiomyopathy. So let's look at side effects in the treatment of, or in selection of an agent. So looking first at haloperidol, it's high potency, so as I said, it can cause more movement disorders. So those can include not just the tardive kinesia that I talked about. It can include acute dystonias, which can happen mostly in the inpatient setting when patients are given antipsychotics parenterally. It can be scary for patients because they lose ability to move muscles, they tense up. It can be treated with anticholinergics, but of course we want to try to avoid that as much as possible. The movement disorder that this patient had was pseudoparkinsonism, which is exactly what it sounds like. Because of the dopamine blocking activity, it can also work in the Niagara striatum. Niagara substantia, and it can cause Parkinson's-like movements, difficulty getting started, cogwheel type rigidity, difficulty with walking, and can increase the risk for falls. So the other thing is that haloperidol in a lot of the first generations can cause hyperprolactinemia. So for that reason, we'd probably steer clear of perfenazine. Of the second generation antipsychotics, risperidone and paliperidone, which is just a metabolite or a derivative of risperidone, can also cause hyperprolactinemia. So we'd probably want to steer clear of those. The other movement disorder that we haven't really talked about much is akathisia, which is a restlessness. These patients have difficulty sitting still. They're constantly moving their arms and legs. They pace. If you ask them how they feel, they say they'd like to jump out of their skin. They just don't feel comfortable in their own bodies. This is a movement disorder. And so this patient had akathisia. And you would want to avoid agents with a similar profile. This is one movement disorder that does show up frequently in second generation. So similar profiles would be brexpiprazole and cariprazine, which are new second generation antipsychotics, and also aripiprazole, which can be associated with up to about a third of patients having akathisia. So now that we've got those down, we know what we need to avoid. So what do we give instead? So the patient has psychosis, so any antipsychotic should work. Because they have a lot of insomnia, it might be good to give an antipsychotic that has sedating properties. And neither brexpiprazole or cariprazine are sedating. In addition, they're associated with an increased risk, dose-dependent risk of akathisia. The patient's not obese, so we can go toward an agent that might be more associated with weight gain, but doesn't have movement disorders, and that would be quetiapine. Quetiapine, incidentally, is if you have to use an antipsychotic in someone with Parkinson's disease. That's if. Quetiapine would be the agent of choice because it is associated with very little movement disorder. So now we have a 57 or 67-year-old gentleman who was admitted for generalized tonic-clonic seizures. It's his first episode. He has a history of schizophrenia stabilized on clozapine 900 milligrams daily. He additionally takes diphenhydramine 50 milligrams at bedtime, bupropion SR 150 milligrams once daily, and metformin 1,000 milligrams twice daily. He does not drink alcohol and stopped smoking 2 weeks ago. So which medication is most likely responsible for his seizures? Is it bupropion, clozapine, diphenhydramine, or metformin? What do you guys think? Ooh, I gotcha. Most of you have blue. And it is true that bupropion can cause seizures, so that's very much the case. So can clozapine. So why is it clozapine over bupropion? It has to do with P450 interactions, which psychiatric medications have lots of. I've got a list for you here. It's probably not all inclusive of agents used for psychiatric conditions and their interactions. It just so happens that clozapine metabolism is induced by smoking. This is important because there's a high correlation of patients with schizophrenia who also smoke. So if someone stops smoking, their clozapine levels are going to go up. Clozapine can cause dose-dependent seizures, and that's probably what happened with this patient. This patient's been taking bupropion, so it might have contributed once the clozapine levels go up, but clozapine is your culprit here. So let's move on to depression. So here's our first patient case. We have a 75-year-old man who's lost interest in doing much of anything over the past few weeks. He's quieter and more withdrawn than usual. He doesn't sleep at night, but spends most of his days in bed napping. He's lost interest in eating and has lost 10 pounds. And he's actually underweight. He has difficulty concentrating on conversations and his mind often wanders. So the question is, which antidepressant would be best? Would it be A, bupropion, 2, duloxetine, C, fluoxetine, or D, mirtazapine? What do you guys think? Okay, I see a lot of yellow, a little indecision. So the best choice here would be mirtazapine. So let's look at why. First of all, let's look at how we identify depression. And I think it's important for you guys to know the diagnostic criteria because we're doing a lot of screening for depression in outpatient settings now. We actually have a screening tool called the PHQ-9, which essentially is just the different symptoms for depression put down as a checklist. So first you can screen for 2 core symptoms that tell you whether the patient is possibly depressed or not, and that's depressed mood or anhedonia, which is loss of interest of pleasurable activities. And this patient has anhedonia, so has met one of the core symptoms. Now let's go and look at the rest of them, because the patient has to have a total of 5 of these symptoms. So he's having difficulty sleeping, right? He's got insomnia at night. He's lost a lot of weight, not hungry. He spends all day in bed, so he doesn't have any energy. He doesn't respond as quickly to things as you might expect and has difficulty concentrating. So he definitely qualifies, and he has to have these symptoms for at least 2 weeks. So he does qualify as having major depression. Anytime you're screening a patient for depression, definitely ask about suicidal ideation. You're not going to make a patient more likely to commit suicide if you mention it, and you're much more likely to catch them and be able to help them if they do have that. So the next concept is, how do you choose an antidepressant? Well, all antidepressants are equally efficacious. So you want to fit the medication to the patient, the pre-existing patient conditions, the symptoms of depression that they present with, and preference for patients. If they have a family member who's responded to an antidepressant, that's always a good choice to start with too. The first-line agents, we used to say that they were SSRIs, but we actually look at a broader class of them now. SNRIs, bupropion, and mirtazapine are all reasonable choices. And let's go through a couple of them. So again, most of providers will go toward an SSRI first. So there are some differences in SSRIs that can influence whether you choose one over the other. So fluoxetine, this one doesn't seem to be working. Fluoxetine hangs around for a very long time. So if you have an older patient that you think is going to be more sensitive to an antidepressant, that's probably not the first choice. Also, fluoxetine is activating along with sertraline. They need to be given in the morning. And in this patient who's having difficulty with insomnia, may not be the best choice just because some of that activation can carry through the day. Paroxetine, on the other hand, is sedating. Citalopram and escitalopram are more neutral. One thing to file away, though, because questions about P450 inhibitors and drug interactions are quite popular. Fluoxetine and paroxetine are 2 of the strongest 2D6 inhibitors there are, so keep those filed away. In addition, citalopram carries a black box warning for a risk of QTc prolongation at doses of greater than 40 milligrams, and paroxetine, unlike the other SSRIs, is a category D in pregnancy. So let's look at the properties of the other antidepressants that I showed to you. So bupropion tends to be activating also, may not be the best choice in our patient with insomnia, and can decrease weight, which our patient definitely doesn't need. It tends to suppress appetite, which is why it's approved for weight loss in combination. Duloxetine is neutral with regard to both sleep and weight. So it might be a reasonable choice, but mirtazapine is both sedating and can cause weight increase. So may be beneficial in this patient. Now this comes with a trick. Mirtazapine has sedating properties at low doses. As you go over doses of 30, it actually becomes activating. So if your patient responds to mirtazapine and you increase the dose, you have to switch it to the morning. One thing I've done here is given you a chart that matches symptoms within depression and agents that can be used to treat it. So what I've got here is the symptom the patient has on the left side of the chart and the antidepressant that can help counteract that symptom on the right. So these agents don't cause these symptoms, they treat them. So if you have a patient with weight loss, for example, mirtazapine might be a reasonable choice. If a patient has insomnia, mirtazapine is sedating, so it might help that. So you can kind of use this chart in helping you to prepare to match patient symptom to treatment. Now we have a 42-year-old woman with major depression who's taken fluoxetine for 6 months without symptom resolution. This should say her physician had her stop her fluoxetine 2 days ago and had her start vortioxetine yesterday. Today she presents confused and agitated, slightly diaphoretic, with a temperature of 99.8. Her legs on voluntary twitch. In addition to vortioxetine, she takes aripiprazole, levothyroxine, rosuvastatin, and zolpidem. So the question is, which medication is contributing to this patient's symptoms? Is it aripiprazole, rosuvastatin, vortioxetine, or zolpidem? What do you guys think? I'm seeing a lot of green, a little bit of the others, but vortioxetine is the correct response, and here's why. This patient is actually experiencing serotonin syndrome. Now, this is something that we hear a lot about, and we may counsel our patients about. Can occur, probably not as often as we thought, but it's something to have a good handle on. So, we know that serotonin syndrome is the highest risk for monoamine oxidase inhibitors. They really do inhibit the breakdown of neurotransmitters, and that can cause an increase of serotonin within the CNS. However, SSRIs and SRIs and clomipramine also have very high levels of serotonin. Well, they are high risk if combined with other highly serotonergic agents. So what I want you guys to notice here is that fluoxetine and vortioxetine fall into that category. I've given you some other agents here. I'd like you to notice that dextromethorphan is on that list. It is metabolized by 2D6. So if you have a patient who's on an SSRI, particularly fluoxetine or paroxetine, they come to your counter and ask you what to take for their cough. Don't recommend dextromethorphan. And while triptans are usually listed, there's some question as to whether that interaction really exists. So serotonin syndrome is a constellation of symptoms that involve the autonomic system, the neuromuscular system, and mental status. The most diagnostic symptoms come from the neuromuscular hyperactivity. So these patients have myoclonic jerks. They can have some rigidity or tremors, and they can lose some coordination. So that's the main part. But they will oftentimes also have diaphoresis or hyperthermia, kind of like neuroleptic malignant syndrome that can happen with antipsychotics, and it is related to that. Also, they can present confused, agitated, even look like they're slightly manic or hypomanic. So here again, we're looking at an interaction. Patient is on vortioxetine, or just went on vortioxetine, but just came off of fluoxetine a couple days ago. What did I say about the half-life of fluoxetine? It's long. So for a lot of SSRIs and SNRIs, you can just stop one day and start the other one the next. But with fluoxetine, you have to have about a 7 to 14-day washout period before you start another serotonergic antidepressant. So that's what's going on here. Fluoxetine is kind of the exception. Of course, this would also happen if I had the patient on an MAOI. You should wait for 14 days after stopping one of those to start another antidepressant. So here again, here's this half-life that's long with fluoxetine. And you see that vortioxetine is metabolized by the same enzyme. So you put them together and you get some fireworks in the way of Serotonin Syndrome. Not welcome fireworks either. So again, you wait 2 weeks to initiate another serotonergic antidepressant. So patient case 6, a 63-year-old man with depression had a lack of response to trials of citalopram, bupropion, and mirtazapine. He has partial relief of his symptoms with sertraline, but still has disabling residual symptoms. He is tolerating sertraline well. His comorbid medical conditions include hypertension, cardiomyopathy, and moderate chronic kidney disease. So which of these agents would you recommend for him? Brexpiprazole, bupropion, liothyronine, or lithium? What do you guys think? This one might be a little tougher. Go ahead and give it a shot. I see a few brave responses. And you guys are thinking along the right lines. It is brexpiprazole for this patient. So good for you guys. This was actually just recently, the agent was just recently approved to begin with, but it was approved for adjunct therapy with antidepressants for the treatment of treatment-resistant depression. So let's look into augmenting therapy, because this has been done for some time. So there are some different ways we do this. We can do dual antidepressants. Usually that's a serotonergic agent plus bupropion, but our patient didn't respond to bupropion. Modafinil is used for narcolepsy and also can have some beneficial effects for patients with depression, particularly if they have the low-energy anhedonic type of presentation. The one that we tend to use the most right now is second-generation antipsychotics. I'm going to back up and say this patient should not be taking liothyronine, which is basically T3. This is used sometimes as an adjunct in depression. For the lithium, he has chronic kidney disease, so we would not want to use that. So let's look a little bit at second generation. So there are a number that have been used. The first one that received approval by itself to add as an adjunct was aripiprazole, which is probably why we saw sales go up so much on that. About 2 or 3 years ago, it was actually the top grossing drug in the country. Olanzapine had been approved for use with fluoxetine for treatment-resistant depression, as well as bipolar disorder. And risperidone and ziprasidone were used off-label. So, and quetiapine, the XR formulation, has approval. But brexpiprazole is the newest kid on the block. So, and you can see there kind of a comparison of side effects. So one of the other reasons aripiprazole is so popular is because it has a low incidence of metabolic syndrome, as does brexpiprazole. But they both have high incidences of akathisia. And this is not something that I can say for certainty, but it kind of appears that the movement disorders and metabolic syndrome are kind of inversely related. So the lower the risk of metabolic syndrome is, the higher the risk is of movement disorders. So that's why brexpiprazole would be the best choice for this patient. Let's move on to bipolar disorder. So the question is, what is bipolar disorder? And I think most of us have learned that it's a down, which is depression, and an up, that's mania. But it's not quite that simple. I have a hypo there in parentheses. There are more more than one type of bipolar disorder. There's bipolar type 1, which is what we typically think about, where somebody is manic, needs to be hospitalized, oftentimes has psychosis associated, and they have destructive behavior. But hypomania is a characteristic of bipolar type 2. So these patients have an up phase, but it's not as elevated as mania. These patients may actually be very functional during their hypomanic phase. It's noticeable that they have more energy, that maybe they're more outgoing, but they usually can function with the hypomania. The issue with bipolar 2 is depression, because they can have serious depression, and it doesn't respond to medications the same way depression does. So the other thing about mania is with the newer DSM-5, not only are we looking at an elevated mood, but we're also looking at an increase in energy or goal-directed activity. So patient may be working more at work, or they may be on a spending spree or be promiscuous. All of those are symptoms of mania. So with elevated mood, it's not always a happy elevated mood. Sometimes patients are dysphoric. And if they have elation, then they need to have 3 of these additional symptoms. If they have dysphoria, it needs to be 4. So in these patients, I think the symptom we think about most is a decreased need for sleep, but they also can become quite expansive and think more of themselves than the proper perspective. They can have pressure speech where they talk so fast it seems like they can't get the words out of their mouth fast enough. And so those are some of the things that can happen with an elevated mood. So let's go ahead and look at the agents that we use for this. We have JL, who's a patient with bipolar disorder, type 1, who has been stable on lithium 900 milligrams a day. He additionally takes lamotrigine, lisinopril, and zabrazidone. He began exercising 3 weeks ago. He has increased his fluid intake and has added energy drinks like Monster to further boost his energy. Today, he presents mildly manic. His lithium concentration is 0.38 milliequivalents per liter. So let's dig into this case a little bit. Which patient-specific factor causes patient's clinical picture? Is it caffeine, hydration, lamotrigine, or zabrazidone? What do you guys think? Very good. I'm seeing a lot of blue, a little bit of red, but it is caffeine. So lifestyle in patients with lithium has to be addressed. First of all, let's look at the lithium concentrations and what's therapeutic. So the general range is about 0.6 to 1.2. When we first treat a patient acutely, we keep those levels a little higher, about 1 to 1.2. But once they're stabilized, in order to minimize adverse effects, we try to maintain them on a lower level, about 0.8 to 1.0. Sometimes we can get them down to 0.6, but if you get much below that, patients are likely to relapse. And the ominous thing about lithium is the more times a patient is non-adherent, the more likely they are to lose the ability to respond to it. So you can have a lithium non-responder. Now, as we know, there are a lot of drug interactions with lithium, and certainly patients need to be careful of that. Some that tend to get overlooked, you can have somebody on an ACE inhibitor and lithium as long as they're on stable doses. That's okay. But if you just put somebody on an ACE inhibitor and they're on lithium, you got to monitor levels because the lithium concentration will go up. But some that tend to be a little more sporadic with patients are if they take NSAIDs. So our young patient who started exercising may end up getting some joint soreness and may decide they want to take, a dose of Advil. So if they're doing this erratically, then they can have bounces in their lithium dose. If they, but now we're going to look at lifestyle because there's a lot of things there that can influence it. So lithium kind of looks like sodium to your body. So as patients change sodium intake, that's going to change lithium intake too. So if they've been fairly careful about their diet and they go on a salt binge and maybe eat a bag of potato chips and have McDonald's, their lithium level is going to go down and they could be at risk for relapse. If they exercise and they don't hydrate well, lithium levels go up and can increase the risk for toxicity, particularly renal toxicity. But caffeine can cause a decrease in lithium levels. So it's important to help your patients understand that caffeine intake should be consistent and, best of all worlds, non-existent. But that's what's caused the issue with this patient. Now we have a 25-year-old man with a 3-year history of bipolar disorder type 1. And he presents to your facility in acute dysphoric mania. So this guy's not happy. He's probably pretty uncomfortable. His urine is positive for cocaine. He has a history of non-adherence with lithium. His current lithium concentration is less than 0.1 milliequivalents per liter. He's not taking any other medications at this time. He denies any homicidal or suicidal ideation. So, which mood stabilizer would be the best choice for this patient? Is it carbamazepine, divalproex, lamotrigine, or lithium? What do you guys think? You guys are getting either shy or tired. There we go, that's a better response. I see mostly red, and that is correct, divalproex. Now, all four of these mood stabilizers can be used to treat bipolar disorder, but we use them in other situations. So, of course, the biggest reason not to give this guy lithium is because he's non-adherent already. But it works better for elated mania, and with fewer responses to therapy. Like clozapine, it also has anti-suicidal benefits, so that's a good agent to consider in those patients. However, if a patient has a dysphoric mood and they have a history of substance abuse, the better choice is divalproex. We pretty much reserve lamotrigine for bipolar depression, and carbamazepine doesn't have as much data to support it, and with all the lab monitoring, we tend to reserve it as third line. So divalproex would be the right choice in this gentleman. So let's go ahead and move on to anxiety. This is kind of a more diverse class. There are a number of different conditions that fall under this, and there are a couple of conditions which are obsessive compulsive disorder and PTSD, which are no longer considered anxiety disorders. They have their own classifications. We still kind of lump them together. So we have a 48-year-old man who's newly diagnosed with generalized anxiety disorder. He reports frequent headaches, which he treats with ibuprofen. His family history is positive for depression and anxiety. So, which agent would give the best long-term resolution of his symptoms? Alprazolam, buspirone, paroxetine, or pregabalin? Okay, I see some energy out there. Yes, good. Okay, great. I see a lot of green, and that is correct, paroxetine. So let's talk a little bit about anxiety and its treatment. So when we're looking at anxiety, we're looking at two major classes: antidepressants and benzodiazepines. So antidepressants are the cornerstone of treatment. The drawback is that patients with anxiety tend to be more sensitive to the side effects of antidepressants, and they take 2 to 4 weeks to really show full benefits. So it can be hard sometimes for a patient to stick with the condition. There needs to be a lot of education with these patients and a lot of coaching. This is a great area for pharmacists to get involved. So antidepressants treat more of the underlying cause, more of the underlying pathophysiology with anxiety. So the flip side of this is that benzodiazepines can give immediate relief of symptoms, although it's more the physical symptoms, the palpitations, the shaking, and the acute feelings of anxiety. They don't really treat what's going on underneath, but patients tend to get rather dependent on them. And if you think about just on an elementary level, it kind of makes sense, right? It's the old stimulus response thing. Patient gets anxious, they take the drug, symptoms go away. So it's a reward system, which is partly why it's more difficult. And that's why we want to try to minimize the use of benzos as much as possible. And the other thing to know about benzos is that they can worsen depression. Now, this patient doesn't have depression himself, but he has that history in his family. So that's another reason you'd want to be cautious. Second line, we can use bupropion. How many of you see this prescribed PRN? It's good to see that that's fairly rare. It's not a PRN medication. It needs to be given on a scheduled basis, and like antidepressants, it takes 2 to 4 weeks to work. And really, it's only beneficial in generalized anxiety disorder. The other anxiety disorders, such as panic disorder, doesn't have so much of a role in. Pregabalin is being used more and more. Anticonvulsant, of course. And some trials, again, this is for generalized anxiety disorder, not the others. But there are studies that show that it's comparable to both benzos, like alprazolam and lorazepam, and antidepressants like venlafaxine. And it's being considered almost first line in some guidelines. I would still recommend going to your SSRI or SNRI first, but that's certainly in there as an option. So now we have a 27-year-old woman with panic disorder who's having difficulty functioning at work. She experienced her first panic attack while getting a cup of coffee. She felt like she was having a heart attack. She has had several subsequent episodes. She can't predict when and where they will happen. Her absenteeism from work is high, and she's concerned about her job. Her medical history is otherwise unremarkable. So panic disorder, well, let's get this. Which agent would most rapidly allow her to return to work? Would it be bupropion, clonazepam, paroxetine, or venlafaxine? You guys are definitely on. It's clonazepam. So just like I said in the previous slide, benzos tend to treat the acute symptoms, and symptoms are very physical for somebody with panic disorder. This really can feel like they're having a heart attack. So again, antidepressants are the cornerstones of therapy. Patients with panic disorder, more than any other anxiety disorder, are very sensitive to drug side effects. And if you think about it, it would make sense. First of all, with anxiety, the amygdala, which kind of helps you respond to stresses and rules a lot of our emotions, is enlarged in patients with anxiety. So it tends to be much more sensitive to what's going on in the environment. These patients already have a higher autonomic tone. Tensed muscles, they can have headaches, and of course the symptoms of panic disorder that feel so severe to them. So any side effect of a medicine, they're already going to be more vigilant about, and their body's already going to be keyed up for. So these patients also need coaching. They need low doses and going slow. So again, we want to be careful about benzos. Panic disorder, there is a particular difficulty in getting patients off of their benzodiazepines, but they are needed acutely. We don't usually start a benzo in somebody with panic disorder unless their quality of life is significantly compromised. So inability to function in daily life. For example, this woman is having difficulty getting to work. She doesn't have a history of substance abuse, so that's good. You want to do short-term benzos and on a scheduled basis, which is why clonazepam might be a good choice. And it's important to know that alprazolam and clonazepam are FDA approved, although you will see others used, and that's fine. So I just wanted to summarize some things here on this slide with regard to antidepressants and benzos. So start with a low dose of antidepressant and realize that it may initially worsen symptoms. It's very important to coach your patient through because they're still going to be anxious and having the side effects. And there's a wide range of agents that we can use for panic disorder. Not just SSRIs, but also venlafaxine XR. I think duloxetine has some data behind it now too. Whereas with benzos, the key here is how are they able to function in their life. So now we have a 24-year-old woman who has obsessive compulsive disorder. Her symptoms worsened when she was treated with bupropion. Treatment with fluoxetine gave no improvement in symptoms. She's currently taking clomipramine at high therapeutic doses. She shows no signs of improvement over baseline and believes her obsessions and compulsions to be entirely real. So obsessive compulsive disorder is no longer classified with other anxiety disorders, but some of the principles of treatment are similar. Let's look at which is the best treatment option. Do you guys think it is to add alprazolam, switch to fluvoxamine, add haloperidol, or add risperidone? Good to see you guys are still active, and you guys are still pretty sharp for this morning. Yes, you want to switch to fluvoxamine. So let's talk a little bit about that. So antidepressants are the agents of choice, but you need serotonergic activity in this antidepressant for a patient to respond. So bupropion would not be an appropriate choice. A fair number of the SSRIs, not all of them, but a fair number have been shown to be efficacious. This is, of course, the only indication for the use of fluvoxamine. Fluvoxamine is a very effective antidepressant, but at the time that the drug was approved, the company chose not to pursue that particular indication. Clomipramine, although it's a tricyclic antidepressant, does have a fair amount of serotonergic activity, unlike the others that have more epinephrine activity. So it can be a good alternative as well, very effective for OCD. Psychotherapy is essential for the treatment of this condition, but sometimes patients need treatment with medication before they have enough insight to be able to participate in their treatment. Benzodiazepines are ineffective, so adding alprazolam would not give any benefit to this patient. So the next question is when do you decide you need to go the next step with somebody with OCD? When are they treatment resistant? And that's when they've had a lack of response to 3 different serotonergic antidepressants. One of these must be clomipramine. So this patient has not reached that point yet. That's why we're going to fluvoxamine instead of the next step. When you get to treatment resistance, one of the things that's sometimes used is second-generation antipsychotics. The most data is with risperidone, although haloperidol is also used sometimes. The thing about treating OCD, though, is that response is very slow and may not be complete. Patients can get tremendous relief from their symptoms without having total absence of symptoms. And they can go from having poor insight, which is believing that their obsessions and compulsions are absolutely true, to having better insight. And while they can't necessarily suppress them, they know that they're not real, and they can do some modification to help with that. So when determining if somebody is treatment resistant for obsessive compulsive disorder, it takes months to decide if they're going to respond to an antidepressant or not. Moving on to insomnia. We have a 38-year-old school teacher who's had insomnia for the past 4 weeks. She has difficulty falling asleep. She awakens after approximately 6 hours and cannot go back to sleep. She took diphenhydramine once, but was too drowsy the next day to teach. She often drinks a glass of wine at bedtime to help her sleep. So, which medication would be best for this patient? Would it be azopiclone, Remeltion, temazepam, or trazodone? What do you guys think? I see a few. See a little indecision, but I see a lot of blue, which is the most appropriate answer. So let's talk about why that is. So we have a number of agents. I'm going to talk first about non-benzodiazepines for sleep disorders. So we have what are called the Z drugs, which are azopiclone, zaloplan, and zolpidem that work at the benzodiazepine receptors, but they don't have the full benzodiazepine activity. We have Surovexant, which is a new agent on the market. It has a novel mechanism of action, which is that it suppresses, it antagonizes orexin receptors. Orexin receptors are responsible for wakefulness. So when you antagonize them, you take that away, and patients are more likely to sleep. For that reason, that agent is contraindicated in patients with narcolepsy. They already have difficulty with their orexin receptors. So if you give them this particular agent, it's going to worsen their condition. We have Clozapine, which is a tricyclic antidepressant. It is approved for sleep maintenance, but of course, like the other tricyclics, it has a high incidence of anticholinergic side effects. And then Reuptake is a melatonin analog. So it works like melatonin, but it's more specific in terms of its interaction with the melatonin receptors. I suppose you could put melatonin in here as well, but then you have to deal with the issues of purity of a product when you're recommending it to a patient. So as you can see here, quite a few of these help with sleep onset. And we have a couple that help with sleep maintenance, like Clozapine and azopiclone and Seroxivent. But there aren't as many. Now, Zolpidem comes in a number of different formulations, including controlled release. But even with controlled release, it's not that it doesn't necessarily take patients through a whole night's worth of sleep. Of these, only azopiclone and Reuptake are approved for chronic therapy. So those are all things to keep in mind when choosing an agent. So let me back up here, actually. So as you see here, the Clozapine would not be a good idea for this patient because she already had hangover effect from her diphenhydramine. Reuptake is much better for sleep onset, and so that wouldn't necessarily be this particular woman because it doesn't have much effect on sleep maintenance. None of the ZEEP drugs are going to help so much with sleep maintenance, but azopiclone is going to get at both the sleep onset and the sleep maintenance and is much less likely to cause hangover effect than Clozapine. Looking at benzos, because we did suggest that was one of your choices, temazepam. They can be used for sleep. It's not the preferred agent, a lot because of the dependence effect, and patients can build a tolerance to the effects. Can also have hangover effects, and sometimes there's also a rebound effect where patients actually have difficulty sleeping, particularly when the benzo is stopped. And depending on how rapidly the benzo comes on, what the onset is, they can cause anterior grade amnesia. Triazolam is particularly typical of this. So and these 5 that I have listed on this slide are all FDA approved as sedative hypnotics as opposed to all the other ones. Doesn't mean the others aren't used. So again, as I said, azopiclone kind of fits all the different conditions in this patient. She'll get to sleep a lot more rapidly. She's less likely to wake up once she's asleep. She will have a decreased number of awakenings, and it will increase her sleep time and sleep quality. So it kind of fits all of the different things that we need from this patient. Just to kind of reiterate some of the things I said, Reuptake is a melatonin analog. It's really good for helping patients who have difficulty with circadian rhythm. So if you have someone who's getting their bedtime confused, this would be a reasonable one to try. There isn't a lot of data yet that supports this, and as you heard before, sundowning is difficult to treat, but there has been some suggestion that maybe this might help. But again, sundowning should be addressed with non-pharmacologic measures first. And it has a fairly short half-life. Now, trazodone is an antidepressant, but you don't see it used at antidepressant concentrations very much because it has dramatic sedating properties. So for an antidepressant dose, a patient would need to receive somewhere between 150 and 300 milligrams. For sleep, just to give you an idea of how sedating this antidepressant is, we usually use a dose of about 50, maybe 100 milligrams for sleep. This is an off-label use, and patients who take this are very likely to have a hangover effect. It has a reasonably long half-life and comes with its own set of side effects. And patients can get dizzy when they stand up. Rarely men can have priapism. Usually there are other risk factors, including vascular disease, for that. So let's move on to substance use disorder. So there are a couple other conditions that I've included under this. This is a subject that probably we could study about for yet another hour, but I wanted to try to target what you guys are most likely to get on the exam. So one, of course, is with alcohol dependence. I have in there a whole section on what to do within the acute setting. Acutely, patients these days are treated according to symptoms with a benzodiazepine when they're first admitted, and depending on what symptoms they have. So we have a patient, 50-year-old, who's been admitted to the medical unit for alcohol withdrawal. He has a 30-year history of alcohol use disorder. His last drink was 3 days ago. He's confused and agitated and experiencing tremors, hallucinations, and tachycardia. Past medical history includes hypertension and cirrhosis. So which benzodiazepine would be best to give this patient? Alprazolam, chlordiazepoxide, diazepam, or lorazepam? And I saw some pretty confident people. I see a sea of yellow, and that's perfect. That's correct. So with benzodiazepine treatment, the traditional benzo that's been used is chlordiazepoxide. There's nothing magical about using this agent, and it can have a lot of drawbacks. First of all, I should back up and say this patient has symptoms of delirium tremens, which usually occurs after the patient's been off of the alcohol for a couple days. It can be a life-threatening condition, so it needs to be treated. So going back to chlordiazepoxide, this is what we used to use to treat delirium tremens, but it has a long half-life, and it also has active metabolites that have even longer half-lives. So because most of our patients tend to have some form of liver disease or maybe a little older, they're more likely to have mental status changes or prolonged effects from chlordiazepoxide. So there's nothing magical about using it. That's just the one we first used. Diazepam can be also used. It also has a long half-life and an active metabolite. And you need to adjust the dose in liver failure. So again, it's one we've used, not the preferred one at this point because of its pharmacokinetic profile. Lorazepam, however, has no active metabolites and it has a relatively short half-life. The dose can be quickly titrated to match a patient's symptoms. So a patient may need a high dose of benzo when they first come in, but as their symptoms respond, you might need to back off on that dose, or might be able to. And you can't do that as much with chlordiazepoxide or diazepam. And as I said, most of the treatment these days is symptom-driven, basically monitoring the patient for symptoms and treating them as they occur, or as the suspicion for them occurring is noticed. So now we have a patient who wants to stop using oxycodone. Timely, right? We have a lot of opioids are front and center in the news. So we have a 24-year-old man who wishes to stop using oxycodone. He's been buying it off the street and takes 160 milligrams daily. He's not interested in methadone maintenance. He would like to enroll in an outpatient program. He is 24 hours after his last dose. He is experiencing some anxiety and muscle aches. He will be initiating his treatment in the clinic, which can happen. What is the best formulation and dose to initiate in this patient? Is it buprenorphine 2 milligrams, buprenorphine 4 milligrams, buprenorphine naloxone 2/1, or buprenorphine naloxone 4/1? What do you guys think? Some pretty confident answers there. Yes, you guys are correct. So there are a number of different ways that opioid detoxification can occur. And of course, you can use methadone maintenance for these people, but it means going to a methadone clinic daily to get the dose. However, we've recently started using Suboxone and buprenorphine to help these patients in the outpatient setting. So there are two forms in which we can do this, just straight buprenorphine or buprenorphine and naloxone. And of the two, the combination is preferred because the buprenorphine can itself be abused. So, and it's particularly true that you'd want to use that combination product in the outpatient setting. So 3 phases of treatment: induction, stabilization, and maintenance. So let's look at those one at a time. So the induction phase is actually initiated in the clinic, and it must be 12 to 24 hours after the patient's last dose of opioid, and our patient definitely falls into that category. We usually start by giving a patient the combination product 4/1 as their first dose, and you want to wait for 2 hours. If the patient still has symptoms of craving, then you want to give another 4/1, and their dose that first day is 8/2. Then the dose can be adjusted on subsequent days based on the patient's symptomatology to a maximum of 32/8. Once you establish that, you know you've got the patient stabilized when they're without symptoms, and they aren't having adverse effects, and they don't have symptoms of cravings. So threefold: no withdrawal symptoms, no adverse effects, no craving. And you can see there what the usual dose is. So usually you don't have to go all the way up to 32/8. In the maintenance phase, you just continue the dose that you determined on the stabilization phase. That can be continued indefinitely. So rather than meth, these patients can be maintained on Suboxone. However, patients should be screened for use, both affirming that they are using the Suboxone and that they're not using other opioids. And of course, like just about anything else, it should be done with counseling. It shouldn't be just giving the medicine. There should be counseling, psychoeducation, support for these patients to help them work through the underlying issues. So patients, of course, you can discontinue a patient from this. You want your patient to be psychologically and medically stable, so hopefully they've gone through some therapy, psychoeducation and psychotherapy. They need to be maintaining a drug-free lifestyle, and they need to also feel that they don't need the medication anymore. So that's a big part of it. Finally, let's talk about smoking cessation. We have a patient who wants to quit smoking. He smokes 1 pack per day. He's been smoking since age 18. He smokes his first cigarette approximately 1 hour after awakening. His past medical history includes asthma, depression, seizure disorder, and cardiovascular disease status post-cabbage, about 5 years ago. His medications include paroxetine, carvedilol, topiramate, levetiracetam, ramipril, and aspirin. He experiences 1 seizure approximately every 6 months. So the question here is, which medication would be best for this patient? Bupropion, nicotine nasal spray, nicotine patch, or varenicline? What do you guys think? Okay, I see a lot of C's. A sea of C's. Yes, you're right. The nicotine patch is the correct treatment, the best one here. So in choosing treatment, there are a number of different things that can be used for treating. Basically 3 different modalities: bupropion, nicotine replacement products, and varenicline. So let's look a little bit more at this. So bupropion, of course, is an antidepressant. Could be used in somebody with depression and is safe to combine with paroxetine. But it also lowers the seizure threshold. We have a patient who's having periodic seizures, so it may not be the best choice. Jumping down to varenicline, it has few drug interactions, But there are some concerns. It can be used for heart disease. Oh, sorry, I didn't mean to shout. It can be used in patients with heart disease, but it should be done with caution. However, this patient also has depression, which can be worsened by varenicline, and it may worsen his seizure disorder. So nicotine replacement products are the most important or most appropriate in this patient. So one of the nice things is that the patch can be combined with a PRN dosage form. Because of the amount of cigarettes this patient smokes, he needs to be started on the highest dose of nicotine patch. He needs to be educated to change it daily and rotate sites. After 2 weeks, he can go down to the 14 if he wants, and then after another couple weeks, he can go down to the 4. For PRN formulations, this depends on a couple of different things. In the gum, of course, you want to teach them about the park and chew. I once had one patient come into me complaining of GERD and was using the nicotine gum. And I'm talking to her, and she's chewing away on this gum, chewing, and she said that she just chews constantly. So I had to educate her that that's probably why she had GERD. So never underestimate the value of pharmacist education. This patient can be maintained on the lower dose. For the gum, inhaler, and the lozenge, the patient shouldn't eat or drink within 15 minutes of use. For the lozenge with the patient, they should dissolve it completely in their mouth, holding it between their teeth and their gum. And this patient has reactive airway disease, so nasal spray is not a good idea. So, and it can be used with a stable heart disease. Okay, and with that, I'm happy to take any questions. Thanks for your attention.